Destiny is the Way Out's deputy director. Steve Adami is the executive director, but Steve's having some connection issues. So I really appreciate you, Destiny, coming on here because I don't want to
fill in the shoes. So
yes, please. Well, in all honesty, you and Steve, you're working on something in a way that is a bit different. As I was mentioning, and I don't know if you heard, the Way Out, and correct me if I'm wrong, is to provide immediate places for people to go when they have that moment, and it may be brief, of clarity to get treatment. Is that correct?
So the Way Out is a little bit bigger than that. That is definitely a piece of the Way Out's charge, but really the Way Out is a recovery focused system of care. And so we run 30 programs in San Francisco, the Salvation Army does, and we get that from a mix of different funding. But really the Way Out is really centered on building out this system of care. And the way you enter into that system of care may look differently. But really what I think our claim to fame and what you're speaking to is our treatment on demand process, where we're eliminating bureaucratic barriers into our recovery wellness center or detox. So each night we serve around 750 people across our 8 housing programs who struggle with addiction. And really, this is an initiative to help people get off the street immediately in real time, help them stabilize, teach them how to live for a few years, give them a place for a few years to practice living, and help them reclaim their lives in the community. And become eventually independent and financially stable.
What's the cost of a program like this?
Well, free to the people now accessing it. It takes a small village in the millions, right? We're running, like I said, 8 different, we have 6 core programs. Residential treatment costs a pretty penny right now. I think we charge around $75 to $115 a day for the cost of a bed. That's whether in detox or a recovery wellness center through residential treatment, which is up to 6 months. But then we have transitional housing, which is about $75 a day per person. And then we have other programs. So you can imagine the cost add up. And we rely on a mixture of philanthropic dollars and also have a combination of government contracts. And then we supplement, right? Like we're here, we're not trying to turn anyone away. So if somebody doesn't necessarily fall into a specific funding pool, we're here to kind of leverage and say, we're here to help you out.
But you're not scaled in a way in which everybody that's homeless in San Francisco can immediately go into your program.
No, not yet. I mean, the idea is that we will scale to add up to 1,000 beds to San Francisco's continuum of care. And really our initiative is hyper focused on individuals who are homeless, who identify as having a drug use problem. That is really our niche. Like we recognize there's tons of other great nonprofits out there serving children, serving youth, and but we're not there to serve those people.
Are you men only, or is this women too? I mean, do you keep them separate? Like, how does that work?
All people, all adults, I should say.
Okay.
So we do have one of our programs is, like I said, San Francisco. We have many programs. We do have a family shelter for families with children, but the core program of the Way Out really just serves adults struggling with addiction.
Go ahead, Kim.
I was going to say, what do you say to people who have seen the money that the state of California has put toward the homeless crisis, and they don't see any difference? It seems like no matter how much money we throw at this thing, it's still the same problem we've always had, if not worse.
I think we leave the people out of the equation. We're so hyper-focused on solutions that we think will solve all, and really we take the human element out of it. Again, just speaking to the people that we serve, I think that by putting recovery, you're an active agent in your own recovery. So you should have involvement in that process. And sometimes we put the cart before the horse and we say, hey, this is a housing problem. We need to build more housing. Let's build our way out of this. And that's, I think, the frustration that I think everyone sees, especially in San Francisco, where we've gone in an all in housing first approach. And yet we see conditions on the street not improving. We see the overdose rates inside homes exponentially growing. And so there's a problem, there's a disconnect here. And I think that's because we've left the human element out of it, that you need to be, prior to getting housing, we need to teach you how to live. And that's really what the way out is aimed at doing, is getting you stabilized. If you identify as having a drug problem, getting you stabilized, bringing recovery to your life, giving you the time to practice that in a community that supports you, and then eventually gaining your independence, getting a job, everything that becomes possible with recovery, we leave out of the equation currently in California and in San Francisco in particular, because we think if we send them to inside a house, problems magically disappear.
And they don't.
And I was of the belief of that at one time myself. I thought, hey, if we surround them with supportive services, they will come. And that's, when somebody is active in their addiction and then you pair that with mental illness, it's really not realistic to expect someone to necessarily participate in services. And
Destiny, I talk a lot about on this show when we talk about homelessness, about the human infrastructure of ideas like this. Are there enough qualified people and enough, and this is physical infrastructure, enough places that will allow this to expand in San Francisco? Because my mind, as you're talking, love the idea. Can already hear the NIMBYs. Oh, that's great, but I don't want that recovery center in my neighborhood. That sounds great, but we don't have enough people or can't pay them enough to entice people to help people out of their drug addiction. Does your program have a shortage of both human and physical infrastructure to expand?
Well, I think the social services world, especially in the mental health side, has a shortage of clinicians. We are seeing a shortfall of qualified people, and that definitely translates to the program level hiring and staffing. We're really lucky that we've raised wages so we can remain competitive, but there's definitely that need, right, that we can never seem to satisfy. I think even on a city level, that's a challenge. As far as infrastructure, we're really lucky being with the Salvation Army is the largest nonprofit landowner in San Francisco. And so we have the physical space to expand, but we just need to pair that with the resources, as we earlier mentioned, to scale to that 1,000-bed goal and build out our continuum.
Is there an effort, as you speak about, the resources, the funding and things like that, to consolidate with other nonprofits that maybe do something similar to what you do and kind of siphon some of that funding away when you can maybe work together? Because that homeless industrial complex mentality that a lot of people talk about is like Kim mentioned, we're throwing a ton of money through all these different organizations. Why can't they coalesce behind a couple of great ideas and then help more people that way?
And that's certainly possible, right? I think that it's going to take everyone to get behind this. I think the challenge is that we all have different strategies at attacking this problem. But there's similar like-minded organizations that we certainly do partner with on an ongoing basis. I can name Mentoring Men's Movement, Solutions for Women, Positive Directions. We have a network of committed individuals. We actually have the recovery coalition that we partner with. So there's lots of people who are attacking this issue from a variety of different ways that we're pleased to partner with.
Well, let's welcome right now Steve Adami. He's the executive director of the Way Out. And Steve, I think I'll need you to unmute your camera. Just look for the little microphone sign and you'll be there. We go. Thank you. I'm glad your internet came back on. So fingers crossed it stays. But I'd love to hear your story as well. And thank you, Destiny, also for all the information. Yeah. And she was giving us some of the nuts and bolts of what the Way Out program is. But Steve, you have a very interesting story about how you became involved in this. Just kind of give us the brief background on yourself and how you became involved in this.
Sure. Well, thank you, Nikki, and thank you for having us today. It's really an important topic to talk about. I mean, San Francisco is really in kind of a crisis, and it's important that we all come together to help solve the problems. But my story is kind of simple. I spent a few decades in and out of jail and prison, homelessness, using drugs. Got out of prison in 2010. While I was on parole, somehow I happened to get a master's degree and got hired by a law enforcement agency and worked in the reentry division of the adult probation department with Destiny. And then over time, got promoted a few times and became the director of the reentry division. And in my time in that role, we designed and implemented close to 60 programs that are all operational today, really focused on helping people kind of rebuild their lives, overcome addiction, and kind of reclaim their place back in the community. So it was quite an adventure. We felt like we kind of solved the justice system. You know, there wasn't a bunch of people left on probation. The county jail count was way down. The prison population in California dropped by about 100,000 by the time I got out of prison. But when I walked outside, I live in San Francisco, when I walked outside my house, it seems like the problems weren't going away.
Right.
And so there was an opportunity to take on this initiative with Destiny and really start to tackle some of really social problems that are driving housing insecurity in San Francisco. So the Way Out is an initiative that really focuses on recovery and coordinates the Salvation Army's efforts in San Francisco into the system of care that is hyper focused on helping people overcome addiction, helping them stabilize and heal, and kind of reclaiming their lives.
Right. Now, what do you think people don't understand that this program can address when we're talking about not just homeless, but drug addicted homeless?
Well, I mean, I think when you look nationally at the drivers of housing insecurity on a national level, then on a state level and the local level, yes, rents are high for everyone. That's true. But our own data tells us in San Francisco, and it's self-report, that 52% of the 8,000 people that have nowhere to live struggle with addiction. Nationally, that number is about 26%. Destiny and I led a 2-year mixed methods research project that we presented to the Board of Supervisors in April right before we joined the Salvation Army. And that data told a different story. And it was really, I think it was 7% of San Francisco's homeless population were interviewed. We also did a subset of people that were in one of our navigation centers that we designed. And the addiction rate amongst people that had nowhere to live was much, much higher. The Billie Holiday Center, which is a reentry navigation center, of the first 200 participants in there, 93% had struggled with addiction and 50% had struggled with addiction for 15 or more years.
Wow.
So what we've done at the Way Out, it's not revolutionary by any means. It's people have been doing these fragmented pieces. The unique thing about the Way Out is that we have all the pieces. So you don't need to go to a bunch of different providers, right? The Salvation Army is the only organization in San Francisco, and I want to say this over and over so people understand this, that we have everything from licensed drug treatment to therapeutic communities, transitional housing, and permanent supportive housing. So some people in the city have permanent supportive housing, some people fund treatment, some people fund transitional housing. We fund all of it, and we have a family shelter all in one. So this system of care is really designed to address people struggling with addiction, and then this helping them get off the streets and healing, and over a 2 or 3 year journey with this, kind of reclaim their lives and return to the community, independent, financially stable, with the ability to just live a happy life like the rest of us.
Do you reach out to the homeless to urge them to go through your program, or do they have to come to you first? Like, is there kind of this outreach, like come get service, or do you wait for them to come to you?
Well, it's a combination strategy. You have to do outreach, right? People in the streets nowadays, they've lost hope. It's different for the last decade. Folks that are living on the streets, I live on 10th Street. When I walk outside and I talk to people on my way to work, they're struggling. And so you have to get out there and talk to people. And what we've done is we created a thing called Pathway to Independence. And it's our guarantee to anyone that if you complete treatment, we will give you up to 2+ years of transitional housing for free, right? So it's one of the 6 core programs of the Way Out. So the Way Out has 6 core programs, and there's about 15 or 16 ancillary programs that work in conjunction once people get through the core programs. But really focused on helping people overcome what's driving their housing insecurity.
What's your success rate? I mean, do people come in? We have one of our questions, comments from our viewers. A lot of homeless don't like rules. How do you overcome that? Is that true? I mean, is that what you experience? I mean, I could also argue maybe they're just not in their right mind to follow said rules. I don't know.
Yeah. What was your first question before the rules? You asked?
Oh, just about the success rate of it. Like when people come in, do they want to follow the rules? That's why I wanted to ask, like, do they follow the program? Is it hard for them to follow the program, to be successful, to get into the transitional housing and eventually be on their own?
So we have a comprehensive data system that collects data amongst all 5 programs. We are 6 programs. We are entering into an evaluation process and outcome evaluation on our programs. So we've only been operational as a system of care that was really intentional for the last 8 months.
Okay.
So we definitely can share some success stories, and it has about, I think it's about 80% of the participants that have entered have successfully exited. That means they left to permanent housing, were financially stable, but the sample size is really, really small. I think nationally, drug treatment's got horrible completion rates, right? So you either have a really hard program and nobody gets through, but the people that get through do really well.
I see.
Or you have kind of like a not really rigid program and a whole bunch of people get through, but they don't do well once they get through. I think ours is a balanced approach. So I'll give you an example. The Harbor Light Center is going to be graduating 19 residents in March, right? When we started working here, there was only 30 people in our treatment center. Today, there's over 100. So folks running that campus have just done an amazing job of creating this culture of inclusiveness where people really feel like they're part of something. And so I think part of that is, yeah, people don't want to follow rules. I don't want to follow rules, right? But at some point, when there's consequences to your behavior, you start listening to people. And what you have to do from a provider standpoint is you have to build trust and you have to build this culture. Like, so recovery is difficult. Anybody that's had anybody that's been to prison, anybody that's been homeless, anybody that's been addicted to drugs, like getting clean is complicated because then you have to deal with life, right? It's just easier not to have to deal with that stuff. And that's what creates some of the tension in people's lives. And what I think what we do different than most people is we're trying to reinstill hope, right? And once people have hope, they can find purpose. And then that's the key, because in purpose comes community. And then once you have this community around you, I think you're set up for success, right? That's why homeless encampments are actually kind of successful. They got all their friends there with them.
Right.
They're living together. They're taking care of each other. We're just trying to create that same culture inside a community that's healthy and reinforces that kind of positive values.
How much, I guess, for people that are listening in the last couple of minutes that we have with you guys, how can people, or what do you need from the public, the people that are watching, to be able to expand something like this? Or what do you need from the city of San Francisco or the state of California or even the federal government to have more of this program expanded in the city and beyond?
Well, I mean, that's going to be something we'll be able to really define in the probably the next 6 to 8 months as we go through this evaluation. So our programs have a blended funding mechanism. So it's some local funds, some state, some federal, and then some philanthropic dollars. To scale, obviously, you want to make sure that everything is working together perfectly, right, and that as we track long-term outcomes, because we're going to be tracking outcomes up to 2 to 3 years post the final program, which is you can actually stay with us for like 3 years. And if you don't have anywhere to go, you can probably stay longer. But from withdrawal management all the way through to really recovery-focused housing, it's a 2.5 to 3 year journey. And so then we're going to be tracking outcomes 2 years beyond that. So I think
so you're kind of at the beginning stage right now is what you're saying.
Yeah, to really make informed decisions about how things are working together. But what I think is important and how we can all work together as a community is we've kind of normalized dysfunction. And it's not normal. It's not normal to live on the streets. It's not normal to shoot heroin in front of my house. It's not normal to not be held accountable for your behavior, right? So the streets have become a mess. And I think what people are looking for is hope and structure and purpose. And I think if we all work together as a community to help people find that, I think we'll be a lot better off. I want to say this because it's something that often irritates me. Housing is not a solution to a drug problem. People do need to get off the streets and they do need to have a place to live, but it's often not the first step. And what we've done now in San Francisco is nobody's even encouraged to go to treatment anymore because they're being told by all these folks, like, we just got to get you into housing. Yeah. We know from the city's own data that of the 3,000 overdose deaths since like 2019, 71% of those came at a fixed address. People had a place to live, right? We also know that 52% of the people that have nowhere to live are struggling with addiction. So yes, rent's expensive. Yes, people should not live on the streets. It's not healthy for anybody, including them. And it's very traumatizing for people living out there. But I think we need to take a step back and really start having honest conversations of the impact drugs are having on people's lives, families, the community, and children. And if we just can have honest conversations about helping people move forward and become whole again, I think everybody will work together better. Like we do provide housing, but the way out is not a housing program. The way out is an initiative that's got a bunch of programs that has one goal: to restore hope and help you rebuild your life so that you can, find purpose, find hope, find joy, and do the things that the rest of us do that make people happy. So,
well, I think that what you guys are doing is awesome. I think that focusing on recovery first is extremely important. So the way out, I want to get the website. The website to find out more information is thewayout.com, I believe. So
it's thewayoutsf.org.
.org, thewayoutsf.org. We will put it. Kim, can you put it in the banner for us right now so people can find it? If you want more information, I'd love to get you both back on to continue to kind of follow you guys in this journey. Especially, we're all in the Bay Area. We want to see this solved, but we do know that the homeless and drug problem extends way beyond our borders. So there it is, thewayoutsf.org. Steve, Adami, Destiny, Pletsch, thank you so much for coming on. I really appreciate it.
Thank you.
Thank you so much. Okay,
Appreciate
bye-bye. Yeah, and so it's just, it's difficult. It's really, really difficult to, just like Steve said, to walk by and know that there's all of these programs. It seems like, right, we're inundated with all of these programs, and they all sometimes take one aspect. This is taking kind of a multifaceted, recovery focused aspect. But what's going on the streets? What is happening right there on the streets? And that's why I wanted to transition. And I'm so excited that I could do these interviews back to back, given that Steve has a history with both drug abuse, imprisonment. Dr. Susan Partovi joins us now. She's also known as the Renegade M.D, Skid Row doctor. You have a bunch of I've been reading up on you. I've been following. She's out with this book. Let me show the book real quickly for people. There's her book. Oh, there it is. Renegade M.D. I have a bigger picture of it. Renegade M.D. is her book. I was able to read a lot of it, doctor. Thank you so much for coming on the show.
Oh, thank you. No, it's very exciting. It was perfect topic dovetail as well.
Yeah. So just to give a little bit of background on what you do. Now, I wanted to kind of go from San Francisco all the way down to Southern California. Of course, Skid Row, infamous homeless encampment. I mean, it takes up so much space and has been there for such a long time. But give us just a brief story of how you kind of became the Skid Row doctor and brought your medical skills to the homeless there.
Well, I started, I'm a family physician to begin with, and we do get a lot of training in mental health. And I've always, I did my residency at a county facility. So I've always been pulled towards working with people who don't have a lot of opportunities, who have less access. And after being on faculty, I switched to working in the community and worked at the Venice Family Clinic in 2003. And they had a very robust homeless medicine program. And after a few years, myself and a couple other physicians started the first street medicine program in Santa Monica for all of LA County. And that was in 2006, 2007, around then. And it was quite an eye opener. There's a difference between seeing people in the shelter, because that means they were actually able to go to a shelter, and then actually going to see them in the streets. And what really blew my mind, and it still does today, are the people who are severely mentally ill and or severe substance users. They kind of go, they often can go hand in hand. Sometimes you can't tell the difference between one or the other, right? So we call them the gravely disabled, who really can't take care of themselves. And California, for sure, just historically has not done a good job at taking care of this population. And so I've been, fighting the good fight, so to speak, of really trying to get the best care to them as possible. And it's interesting that Steve was talking about treatment first, because I agree that especially with the severely mentally ill, like really in the throes of their psychosis, getting them a place to stay. They, first of all, they don't want to be housed, right? They don't think anything is wrong. And so, so treatment first for a small proportion of people who are living in the streets might be the way to go. And so aggressive treatment, starting them on antipsychotics in the street, switching them to, there's now a shot, there's a few different medicines that are long acting, up to 6 months.
Oh, wow.
It really is a game changer. And so, so one of the things I am trying to do is really increase access to people who are out in the living in the streets to these miracle medications, and also get people who are in the outreach world. So it could be nurses, clinicians who don't feel comfortable treating psychotic symptoms, and really kind of training them to become more comfortable, because there's just not enough psychiatrists out there, and they have a really hard job, and it's a difficult specialty to be in. So
Yeah.
What are the medications that you reference do? Are you talking about the drugs that, or the medications that you give to someone that counteract the effect of drugs, or what do you?
Antipsychotics, I would say,
No,
or something like that.
So there's a lot of gray area between mental illness and substance use, right? There are medications that help with substance use. Most of them are psychiatric medications, so like to deal with cravings, right? Or there's replacement medications, say for opiate use. There's like buprenorphine that can be used to basically not feel high, but also don't have the symptoms of withdrawal from opiates. But then there's medications for psychiatric symptoms or psychotic symptoms, but it could also be for PTSD, depression, anxiety. But the ones that are really, I call the super dupers, are the ones that are exhibiting psychotic symptoms. Now, the psychotic symptoms can be from schizophrenia, but lately, methamphetamine use has been a huge culprit of causing psychotic symptoms, so much so that a third of people who have psychotic symptoms, even if they stop the methamphetamine use, they go on to have persistent psychotic symptoms after 6 months. So we're seeing a really big uptick in psychotic symptoms. And when someone is in the throes of their psychotic, they are at such a dangerous place in their life. And so trying to get to them and get the care they need before they go to prison, before they go to jail, before they get hospitalized, or before they die. So that's
how did you get into this community? Now again, if you're just joining us, Dr. Susan Partovi works along Skid Row. I can only imagine, I don't know, sometimes I would feel scared to approach people that are in the throes of a psychosis or possibly on drugs. Just on a personal level, like, how do you get over that? Have you just developed the trust, or do you just kind of push through, or your experience in your career has prepared you? Because I'm sorry, I have a heart. I'm empathetic. If I saw somebody walking down the street, someone in our comments was mentioning a woman walking down the street naked, I would feel scared to approach this person and help, and I feel bad about it.
Yeah. So it takes a little bit of a little bit of skill. Like if someone's like really angry and they're yelling at their voices, we're not going to approach them. Okay. But if someone's just talking to themselves, they're not dangerous. And in fact, when someone's like talking to themselves and then you go, hey, Kim, how are you? They'll be like, hey, doctor, how's it going? Like they can snap out of it and come back to like sometimes to a quote unquote normal conversation up to, maybe a minute or so. And so you just have to gauge. But the crux of street medicine or street outreach is building a relationship with the people. And so so at first you might, like for example, a couple of weeks ago, it just started getting really cold here. So I went to the 99-cent store and bought a bunch of, hats and earmuffs and gloves and stuff. And it was a great hit. I was like, I was almost like christening people with a hat,
Right.
like, it's kind of cold out. Do you need a hat? And they're like, yeah, sure, thanks. And then you can start. It's what we call an engagement tool, right?
Yeah.
And so you can say, hey, how's it going? What's your name? And one person, we gave him a hat, and it turned out to be his birthday.
Oh.
And and it just depends. Like if they're willing to talk to you, you can just say, hey, I'm a doctor. Do you need anything? I'm trying.
So do you provide as a doctor things like clean needles and bandages if they're injured, or do you treat them, kind of triage them if they have any injuries?
Yeah, I mean, street medicine, kind of originally, you have your backpack and you have your medicine and gauze and tape and, saline and stuff if you have to. Nowadays, thank goodness, most people have Medicaid or Medi-Cal in California. And so what we can do is if they need something like an antibiotic or a blood pressure medicine, we can call it into the pharmacy. Our outreach worker can go pick it up for them and then bring it. So, but yeah, usually you have, some creams in your backpack and bandages and stuff like that. But what I'm trying to do is actually, so I have samples of antipsychotics in my backpacks. So I'm actually trying to find the sickest of the sick and really just start saying, hey, are there any medications that you might need refills on? Like,
Right.
and then they're like, yeah, I do need a refill. Okay, what did you used to be on? Did you take this? Did you take that? And I have a few different ones in my backpack, and if they've been on one, I can give them a shot. So I did that with the guy it was his birthday. I'm like, let me give you the long acting shot. And he knew the medicine. And so I was pretty confident that he had been on it before. And and so the idea is it'll stabilize them. And it works pretty quickly too. So it's kind of nice that their thinking becomes more organized.
I have a question on a personal level, because it seems like, just hearing you talk about it, that it's satisfying work. Obviously, you became a doctor to help people, and here you're helping people that need the most help of all of us, right? But on a personal level, when you go home, are you just dragged down and frustrated that you're seeing the same people over and over and you can't quite get them to not be in the position they're in? How do you cope with the cycle of homelessness and kind of putting band-aids on it but never really being able to fix it?
Right. Well, no, we do have successes. It's a very mercurial path of emotions. And so I always say that the highs are high and the lows are low.
Yeah.
And so, for example, one of our patients, we just started doing specifically outreach in Skid Row to look for people with severe mental illness. And we had a guy who had been receiving medications, just got transitional housing, and 2 weeks ago he passed away.
Oh, I'm sorry.
So yeah, so that, and I was on vacation, and my colleague called me to ask me, hey, I'm hearing this, can you look it up? And sure enough, it was true. So yeah, that really sucks. And but then the highs are high when you meet this guy who's his birthday and he accepts the shot, and then he's like, he has a phone number so we can call him, so when his next shot is due we can find him. And so it's definitely a few steps forward, a couple steps back. Right. It is a very like I said, up and down.
Yeah.
Highs.
What about the existence of Skid Row in general? Some would argue that some would say, in my opinion, there's kind of two main thoughts, right? One, like our previous guest Steve was mentioning, you know, it is a success. They've created a community. They can depend on each other. They can people like yourself can find a large group of people to provide whatever
Yeah.
services they can to. On the
Yeah.
other hand, it's
Yeah.
a big flashing light of people need help, and you're just allowing this to exist. I mean,
Yeah.
should Skid Row exist, and not just exist for as long as it's existed?
Right. You know, it started in the 20s and 30s around the Depression,
Right.
and it was mostly you know, alcoholics, and well, also it started because they had these single units, so people would come to work and stay at these hotels where like the single, you know, single male unit kind of thing, to come and work. And then when work started declining is when people couldn't afford these units and they just started hanging out in that area. And then the 80s happened, where you know, the crack surge, cocaine surge came about, and
And the closing
yeah,
of mental
so,
institutions, right? I mean, a lot of these people are mentally ill.
so a, a big, I would say at least half, if not more, for Skid Row, not all of the homeless population, but are severely mentally ill. Now, there could be an uptick because of the recent meth use, the surge in that. Should, you know, there has been, I mean, just to let you know, there has been a lot of work to getting people housed in Skid Row, and there's they're, you know, cleaning up streets on a regular basis. I've heard of people who've been there for years getting the help they need and getting housed. I think that if we could treat mental illness the way it's supposed to be treated, I think half of Skid Row would be gone, for one.
And how do you envision that?
we need more assertive treatment, like street treatment, because they're not going to make it to the clinic. And then we need to be able to put them somewhere where they can be stabilized. And so it doesn't necessarily have to be a hospital, but it has to be a place where there's high level of care, 24/7 care. And if they're so bad that they are at danger for themselves, then yeah, they need to be hospitalized, and it shouldn't be so freaking difficult. I can't tell you how hard it is to hospitalize someone, and not just to hospitalize them, but to keep them there for more than 72 hours, because
Right.
you don't get better in 72 hours.
No.
In my book, I talk about marinating. You really need to marinate and in order to stabilize. And I get that it sucks to have to take away people's, you know, freedom. And I'm not saying it has to be like that for the rest of their lives, but there needs to be a structure that allows for aggressive, assertive care and treatment in a nurturing environment. And then there needs to be the gradations that is needed. Everyone's at a different level of need, right? There's some people who have really high level needs, and there's some people like can, you know, live a normal life and live on their own. But we have to have that full spectrum available, and we really don't. And the reason is because there's not a funding stream for it. Right. Medicaid does not pay for it. Medicare does not pay for it. And so it's, you know, the counties are basically holding the bag, and it just depends on which county, you know, has more money. LA has a lot of money, and so I think we do a little bit better than other counties. But yeah, it's a struggle.
It sounds like then what Governor Gavin Newsom is putting in place with the care courts would be something you think might work. Is that?
Yeah. So
okay.
I've been involved in helping implement care court on a state level, and the idea is really to reach out to the people, again, the sickest of the sick,
Mhm.
and to provide resources for them. So it gives the county an excuse to go find people. And so what's different about this program than any other program is that the family members can petition for their loved one to be taken care of.
Right.
And so what the county does is they get that referral and they have to go look for them. And there's an accountability set up that they need to be looking for them. And when they find them, they need to be offering them services. So it's kind of cool because it allows for an avenue of these mental health workers to look for people, find them, and then offer them services. And then there's different avenues that they can go. So if they accept services right away, which many have, they don't have to go through the court aspect of it. They can just start getting the resources that those programs have in existence.
Right. We have a question for you. What do you think of SB 43 that would expand 5150 criteria? Would it help? But we don't seem to have enough 5150 beds.
Exactly. So yeah, I was actually very much a part of trying to get that passed with Eggman's team. And we actually have been trying to expand the definition of grave disability for a while. And so it is miraculous that we were able to do that. It's a little bit of a bummer that most of the counties, except for San Francisco, are wanting to delay it for a couple years. So that the conundrum is, yes, we want to be taking care of people that fit that criteria, but the writer is correct in that we don't have enough beds right now. But Proposition 1
Right.
is going to kind of divert some monies to create what we call housing that heals. So it's not building institutions per se, but it's building places where people can
Transition
get well,
into.
get stable, maybe step down, then live. So that's really the hope behind Proposition 1.
Why do
So
you think it's so bad? Maybe I don't know. I mean, I don't live. I know we're a gigantic state, but do you think that it's worse in California? And why do you think that is? If you do,
yeah, so we're given a grade F by the Treatment Advocacy Center, and it's interesting. So there's a oh gosh, E. Fuller Torrey has written several books about this, and he writes about the history of mental illness and treatment over the centuries. And what I realize is that a big part of it is definitely the economic aspect of it. But with California, it also was the civil liberties aspect of it. And so California is very proud, and rightly so, for taking such a stance on civil liberties, right? And that has been kind of they've included severe mental illness as part of that. So historically, California has been very strong on civil liberties, which I don't disagree with. However, it's kind of allowed the pendulum to really swing the other way, to where any kind of progress to where we can, in my opinion, take care of people in the aggressive way that they need to be taken care of. The ACLU or the disability rights group in California are very much opposed to this, and so it's difficult. And I'm not against these. I mean, they both do really good work in general, but on this issue, they have blinders on, in my opinion.
yeah, it seems a bit misguided when again, you're talking about people that may not be in their right mind. So they need help. I mean, that's the whole thing. It's like they need somebody to advocate for them, even if it does seem like it's a taking away of their civil liberties, which, I mean, they need help. I feel like this is what I always say. If somebody's literally laying their body down at our feet on the street, they're begging for help, whether they are with it or not. And that's what's so,
Have
it's
you
so
ever
surprising it's gotten bad.
Have you ever seen someone in such bad shape hollering on a street corner in San Francisco or what have you? And at least my thought is, and because I'm incapable of doing the things that you do, why doesn't someone do something? Why don't we do something? How can we let people be like this?
So, unfortunately, and I don't want to put the blame on anyone. I think the cops have a very difficult job, especially in Skid Row. I mean, we have people literally dancing in the streets as cars are whizzing by, and half naked, all naked, and the cops that have been there for years or decades, they know if they do, LAPD is allowed to do a 5150. So in California, that's the 72-hour hold, and they're allowed to take someone to the hospital and say this person needs to be on a hold. They're out in 72 hours, back in the same freaking place.
Yeah.
So it's demoralizing to them, I would imagine. And then same with psychiatrists. Again, they have a really hard job. Like, how many people come to General Hospital in Los Angeles needing care only to know that, we can't, there's nowhere to put them. So even though the definition of grave disability has been expanded, we now need to hold the community accountable, which means we need to have more places to put people.
Yes.
And so again, more places for housing that heals is kind of the catchphrase that we use. And it does include, medically necessary involuntary care is part of that spectrum, right? But again, we want people to be, the most autonomous as possible, but sometimes they need to be taken care of against their will.
Exactly.
And I use, in my book, I do use an example. I've had to take care of my mother who has dementia, Alzheimer's. And then my sister, actually, in her 50s, developed a pretty rare type of early onset dementia. Yeah. So I had to take care of both of them. And so dementia, especially with my mom, in her 70s, 80s, you'd say if someone is wandering the street and they have dementia, like my mom escaped her caregiver once. And so I'm calling the police and they're like, oh my God, this is an emergency, right? Mm-hmm. But if it was my adult son who had severe mental illness, they would be, oh, well, he's an adult and he can take care of himself.
Right. Yeah. It's that initial
so there's a disparity. So there's a disparity there. And then if I had, the example that I use in the book is, if you had a 5-year-old child who needed chemotherapy but was tantruming, saying no, right, would you go, okay?
No, right. Exactly.
And I'm not saying that these adults that suffer from severe mental illness are children, but a lot of times they are at the executive functioning or developmental capacity of a child. Mm-hmm. And so we have to, and you don't strap the kid down, like you talk to them, you try to do whatever you can. And it's the same thing, with the adults. We're not saying and I get it. There was an article that did say that, there was too much use of restraints, and I agree with that. And yeah, we have to definitely do better when we are taking care of people against their will.
So
and
what do you need, like, for people like you, and you're getting so many compliments in our comments about, being out there, you're compassionate, and I think people want to see more Dr. Partovi's out there on the streets of
right.
Skid Row, San Francisco, all around the country and the state of California. But what do you need? I know obviously at the state level we have the care court, we have these bills that are trying to
yeah,
expand the definition,
yeah,
but on the ground, you're on the ground practicing this street medicine.
yeah.
What do you need, and what message do you have for those that maybe want to do what you do?
So I think me personally, I'm out there to work with the sickest of the sick. And so when I talk to other street medicine or street outreach people, I'm telling them to call me if they have needs about addiction or psychiatric needs. I mean, obviously, there is this in LA. It's great that the Department of Mental Health does have an outreach team, an outreach psychiatric team, and yet it's still not enough. So I think the primary care clinicians need to become more comfortable with treating psychotic symptoms. If someone's in the emergency room, the emergency doctor can start, just like we are doing with Suboxone or buprenorphine, become comfortable treating people with psychosis, refill their antipsychotic meds, give them the shot if they were on it, refill that, have that available in the ERs, in the urgent cares, just because there's not enough psychiatric urgent cares and ERs to go around. And unfortunately, the medical ERs are the big dumping grounds for people with severe mental illness, and
Which
so
is expensive too to handle these people as well.
right, and to have and to create a better flow for people who are severely mentally ill, and not just let them out on the streets, but take care of them, and let's start building more housing that heals, so that we can take care of these people. I love that Governor Gavin Newsom is really passionate about taking care of this population, and he's really trying against a lot of challenges and backlash and criticism, and so I would hope that as a community we can change our culture to say, this could be my mom, this could be my sister, this could be my kid, and you know what, this is someone's mom, this is someone's sister, this is someone's kid. And I can't tell you how many family members I have met who are so desperate because their kids out in the street in the cold, in the rain. And I mean, I literally talk to someone every day, and it's so heartbreaking. And so, to have that compassion for people's loved ones, and think of someone as someone's loved one. That's kind of how I do it. And I start at the beginning of my book saying, like, when I first started doing street medicine, I was out in Santa Monica on the promenade, and there's this elderly woman in her flannel pajama with little pink roses on the pajamas and slippers, like midday, asking for money. And, she looked like she might be in her 70s, which nowadays is not very old, right? But at the time, my grandmother was alive. And I'm like, I'm sorry, if I saw my grandmother out in her pajamas,
you would help her.
Not only help her, I would, she was 4'9", right? I would grab her under my arm and throw her in my car. And, because she was the matriarch of our family, I come from a Persian Jewish family. There's no freaking way we're going to allow grandma to be homeless, asking for money. I don't care if she spits in my face, knocks me down. It ain't happening, And so if we can all have that same philosophy, of like, there's no freaking way grandma's going to be out in her pajamas and promenade asking for money. Right? It's just not happening. So,
Dr. Susan Partovi, I'm going to show your book. It's
Okay.
called Renegade M.D. It's a very easy read. I mean, it's filled with stories of people you've helped, the people you've met. And it can be a tough read at times just because you know that people are going through this. I appreciate your work. I'd
Aw,
love to
thank
have you
you.
back on again.
Aw,
Keep up the good fight. If there's anything that we
aw.
could do or help you promote besides your book, of course, let us know, because this is a huge problem. And like you said, it could be anyone we know. And someday it could be a person listening right now. You never know what's going to
Yeah.
happen in a person's life. So
Vote,
Dr.
vote,
Susan,
vote
thank
yes
you.
on Proposition 1 in March.
There you
That'll,
go.
Yeah.
that'll
Oh,
help.
yes. All right, Susan, Dr. Susan
Okay.
Partovi, thank you
Yeah.
so much. Have
Thank
a
you
good week.
guys. So
Thank
great to
Okay.
see
you.
you.
Bye.